Hello, my name is Nittaya Phanuphak and I'm the Executive Director of the Institute of HIV Research and Innovation, or IHRI, which is based in Bangkok, Thailand. It is my great pleasure to be given this opportunity to share with all of you about the implementation of the status-neutral approach in HIV programs as part of the Chinese HIV Clinical Forum educational series today. In this talk, I will briefly review the global gaps in achieving HIV treatment and prevention goals, and then we'll discuss the status-neutral approach in HIV programs, and we'll then give you some examples of how same-day ART initiation and same-day PrEP can be implemented through the principles of demedicalization, simplification, and differentiation. I would like to start by saying that even with great ART, we are still seeing large gaps in the UNAIDS 95 testing and treatment targets. And we currently only have 2/3 of people living with HIV who are virally suppressed, and less than 3/4 of people who already know their HIV status successfully started ART. And after 10 years of having oral PrEP with more than 99% effectiveness in HIV prevention, if taken correctly, we now still have less than 1 million PrEP users globally. And this is only 28% of the 3 million PrEP user target set by the end of 2020. And outside of sub-Saharan Africa, we can also see that key populations contributed to 93% of new HIV infections. And among these new infections, almost half occur among men who have sex with men and transgender women. And these are populations who in many countries are still being criminalized or marginalized. So to end HIV by the year 2030, we all know that we have the tools ready. We have great ART to treat people living with HIV, and we have great PrEP to prevent people from acquiring HIV. And through the status-neutral approach lens, we now must equalize both HIV treatment and HIV prevention. For individuals who come in for HIV testing, if they tested HIV positive, they will be offered antiretroviral treatment immediately in order to bring them as quickly as possible to the final goal of having zero risk of sexually transmitting of HIV. This is also known as U equals U, or undetectable equals untransmittable. But at the same time, for those who tested HIV negative, they would also need to be provided services with equal importance and urgency. And in this case, PrEP as part of the combination HIV prevention package will be offered to them immediately in order to bring them as soon as possible to the goal of having almost zero risk of acquiring HIV. But we do know that the uptake of these tools, HIV testing, ART, and PrEP is not optimal because of the still very strong and pervasive stigma related to HIV, stigma related to the characteristics of key affected populations, which could be them being in the sexual and gender minority groups, them being engaged in sex work or engaged in substance use. And moreover, the HIV services themselves, like HIV testing, like PrEP, like U equals U, also have their own stigma. There are PrEP stigma, there are U equals U stigma, because these services are linked to HIV, are linked to sex, are linked to sexual pleasure, which are all taboo in our region. There are also beyond the status neutral approach to HIV program. There are also this people-centered service delivery in which there are 3 principles to guide this people-centered service delivery that I also would like to discuss here. The first principle is the demedicalization. And the demedicalization is to know which clinical services can be demedicalized, can be task shifted to lay providers, to community, or even to the individuals themselves. This is to move away from facility-based services to community-based services, and or to eventually making these services being available in a way that is called the community-led services. And the second principle is the simplification. And this is to know which clinical steps can be simplified or even can be removed. And this is to move away from the nice to have services to the must have services. And the last principle is the differentiation. And this is to know which clients need more intensive services or need less intensive services so that we can differentiate our limited resources accordingly. And this is to move away from the one size fits all approach to the custom tailoring one. So now let's start with the first arm of the HIV status neutral approach, the treatment. And I would like to discuss the same-day ART initiation, which can be implemented successfully through the principles of the simplification and differentiation. I will give you an example in Thailand, where we already included same-day ART initiation in our national guidelines since the end of 2020. And the guidelines now recommend that any individuals newly diagnosed with HIV or those who are re-engaged clients already known that they have HIV should have ART initiated on the same day, on that same day of HIV diagnosis, or the first day of the client coming into the hospital if HIV testing is not conducted in the hospital. And this can be done using only history taking, physical examination, and chest X-ray to rule out tuberculosis and cryptococcal meningitis prior to ART initiation. Blood draw for CD4 count and other baseline safety laboratory testing can be done, but the results can come back a few days later. We don't use that lab results to determine whether ART can be initiated. And then ART can be given out on that same day of HIV diagnosis or the first day of hospital visit. And a 2 to 4 week follow-up visits will be scheduled to check on the side effects. And after that, 3 to 6 months MMD can be implemented, or the multi-month dispensing can be implemented. All these hospitals that are doing the same-day ART initiation will use U=U as key motivational message to start and maintain ART for their clients. And in Bangkok, same-day ART initiation has proved to be quite successful. Now we can see that more than 80% of people newly diagnosed or re-engaged in care can have their ART initiation conducted on that same day, on the first day of clinical hospital visit. And the rest of ART initiation can actually happen within the first week of HIV diagnosis. The retention rate has been high, above 95% throughout the first 2 years after ART initiation. And the viral suppression has also been high, above 93% after at least 6 months of ART initiation. And we can see and learn now that we can further optimizing same-day ART initiation through the use of telehealth, and this is through the principle of demedicalization. This is where we move the ART follow-up visit out of the hospital, out of the clinic, to client's home, to client's workplace, through the use of telehealth. And during the COVID-19 pandemic, this has been proved to be very feasible and acceptable both by the providers and by the clients. And we can see that there has been no difference in referral rate or in retention rate among clients who received telehealth follow-up compared to those who received in-person follow-up. So the use of telehealth has helped a lot for Thailand to continue the ART initiation even during the peak time of the COVID-19 pandemic. And recently, WHO has also further simplified its recommendation on same-day ART initiation. And the previous recommendation of the brief delay of ART initiation for people living with HIV with suspected TB has now been removed. And now WHO recommends to start ART for people living with HIV with suspected TB, except for suspected TB meningitis. They can start ART while rapidly investigating for tuberculosis. So you can see how we can apply the principles of simplification, differentiation, and demedicalization for ART initiation. Now let's shift to the prevention arm of the status neutral approach. And I would like to use the example of same-day PrEP service, which will demonstrate how we apply the demedicalization and simplification principles to make this feasible. And this is an example of same-day PrEP service in key population-led clinics in Thailand. In this model, once the client comes in to key population-led clinic, the lay providers will be the one who deliver the services. Lay provider will do blood draw and perform rapid HIV testing. And then the lay provider will share the HIV test result with a doctor in a remote hospital via this online chat application. The doctor will then review lab results and then approve the prescription of PrEP so that the first bottle of PrEP or the 3 to 6 bottles of PrEP refill can be given out by lay provider to the client almost within the same hour of the client first comes into the clinic. And this key population-led PrEP service has been the main PrEP scale-up strategy in Thailand. You can see that almost more than half of PrEP users in our country has received PrEP through this key population-led PrEP service, as demonstrated by the blue-gray section and the bright blue sections in this graph. However, even that now Thailand has included PrEP as part of its universal health coverage as a pilot phase since October 2019, and now as the full phase implementation since October 2021. We only have like just around 1/5 of those who should benefit from PrEP in our country, according to the PrEP target exercise made a few years ago, who ever received PrEP once in our country. So more efforts are needed in PrEP scaling up. And the success of key population-led PrEP is due to the model being part of the key population-led health services, or KPLHS, which was established in Thailand in 2015. And under this KPLHS, HIV services, sexual health services, and other related services are designed and co-delivered by key populations themselves. And this is through the principles of demedicalization and simplification. And the services are made in a way that it ensures that services are needs-based, demand-driven, and client-centered. And services are delivered by trained and qualified and certified lay providers who are often members of key populations to ensure the non-judgmental and stigma-free environment of service provision. However, it has not been easy, or I can say that it has been very, very challenging to make key population-led health services and the roles of key population lay providers being accepted by healthcare professionals in our country. And it has taken us almost 5 years to gradually advocate for this change. And by 2019, according to this Thailand Ministry of Public Health regulations, key population lay providers can now perform finger prick blood collection and STI sample collection. So this includes throat swab, rectal swab, and the collection of urine for STI testing. And they can also perform point-of-care laboratory testing for HIV and STIs and report these test results to their clients. So this includes the use of rapid HIV testing, rapid syphilis testing, or rapid anti-HCV testing, as well as the use of point-of-care molecular testing for gonorrhea, chlamydia, and hepatitis C. They can also dispense PrEP and PEP and oral STI drugs as prescribed and can be remotely by the doctors, as already mentioned. And this success in legalization of key population-led health service cannot be made possible if we don't have a strong data demonstrating that more than half of HIV testing among key populations, as well as more than half of PrEP services provided to key populations in our country, are conducted by these key population-led providers in just only 11 clinics in 7 provinces, compared to the rest of the services which are provided by more than 900 clinics and hospitals in every province in Thailand. Here, the key population-led health service success comes because they fill in the service gaps for key populations, as services are designed to be accessible in hotspots and during flexible service hours, which fit the lifestyle of key population. Services are also designed to be available in a way that it is needs-based and client-centered, and the services are tailored according to the priorities, health priorities set by each key population. So, for example, you will need to have gender-affirming services integrated into these services for transgender people. You will need to have legal consultation service available for services provided for sex workers. Services are also designed to be acceptable, to be provided in a non-judgmental and stigma-free environment, as already mentioned. And lastly, the services are also of high quality, provided by trained and qualified and nationally certified lay providers. So to conclude, I would like to say again that the status-neutral approach to HIV can change the paradigm of HIV programs by emphasizing equally both treatment and prevention to end the HIV epidemic. And the demedicalization, simplification, and differentiation are three key principles which can use to facilitate service delivery design, aiming at bringing HIV testing, HIV treatment, and HIV prevention to those who are in greatest need. All of this could be achieved not only through health technology and innovation that we already have, but also with the healthcare professionals' open mindset. I'd like to end by acknowledging all the implementers, partners, and funders who have made these initiatives possible. Thank you very much for listening.